are live. Hello, everybody. Welcome to another episode of Luncheon with the Experts, a Carcinoid Cancer Foundation, brought to you by, we have a special announcement actually about that today. Tercera has acquired Zermelo from Lexicon Pharmaceuticals. And for additional information, you can go to their website, but we would like to thank Tercera Therapeutics for their support of Luncheon with the Expert series and announce that they have acquired Zermelo. Tercera will be the sponsor of the Luncheon series going forward. So this is really exciting. Lexicon's clinical nurse educator team has transitioned to Tercera, so there will be no disruption in Zermelo nursing support for NET patients. And if you'd like to speak with a clinical nurse educator, please visit CCF's website, carcinoid.org. And on the homepage, you'll see more information in the latest news section. So big news, and we'd like to thank them. And we know that transition will go smoothly. I am Rain Bennett, your host for today, and I've been working with CCF for about 10 years, creating films and videos to help educate the public, patients, caregivers, the overall NET community about this disease. And so if you're familiar with the show, each week we take a deep dive and have a conversation with a member of the NET community. That might be a doctor, that might be a nurse, that might be a patient, that might be a patient advocate. And it's really exciting to me because this is such a strong community. And as we all know, it takes a village, as they say, right? It takes this whole community to bind together. And all those role players are super important. Before we get started with today's guest, we just want to have a disclaimer from our sponsors that we want to say that the opinions expressed by the guest presenters, as well as the questions asked by the audience, haven't been created or suggested by the sponsors. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation, and audience members should not rely solely on these opinions and information expressed by the guest, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. So all that is really saying is we're going to give you some guidance today. Hopefully we're going to share some information, but we don't know your case, and we can't get too case specific with everybody because we have lots of people attending these Facebook Lives. So just know that you need to discuss anything you do moving forward with your home team, your medical team. Today, our guest is Pamela Ryan. How are you, Pam?
I'm great. Thank you. How you doing?
I'm doing great. You know, for those that don't know, I just got to see Pam not too long ago in real life, which is a privilege in 2020. Another thing I do with CCF besides this show is different videos and a video series that we have been releasing videos this year. And so we got to do an interview. It was the first time I had been on a trip like that in about 6 months. And so I got to spend some time with her down there in Louisiana. So Pam, for those who aren't familiar with who you are and what you do and where you do it, tell us a little bit about how, what role you play in this neuroendocrine cancer community.
Well, I'm Pamela Ryan. I'm an oncology nurse navigator at Ochsner Medical Center in Kenner, Louisiana. I've been in the neuroendocrine world for about 15 years, so I've been in it to win it with a lot of the oldies and the experts. So I had the privilege and the honor of learning a lot and being exposed to the best of the best, I have to say. What I do day to day is I navigate. And actually, although I just took this role on a couple of years ago, it's a new role that was created at our facility. We kind of had a satellite clinic. I navigate patients through the system, whether it's helping them through their cancer journey in any way I can, whether it's time points such as surgery or procedures in the hospital or PRRT, or just coming into the clinic. I make sure that they have what they need, whether it's just an ear to listen to or scheduling or making appointments, educating, transitioning them home to their local doctors. Anything that the patient needs, I help make that happen. Truly advocacy right here. So little did I know, I was a navigator all my career. I just finally, I got the title. And after I transitioned into this role, I kind of really thought about it. It's not a whole lot different than what I've done for the last 15 to 20 years. Even longer than that, because I did it in another arena. I did it in transplant as well.
Awesome. Well, we talked a little bit about it when we met and I worked with you a few weeks ago. I'm excited to talk to you today because of the role patient advocacy plays in what you do. That's what, I mean, I really love. Obviously the doctors that we have on the show and all the technical information is everything, right? It's not even enough to say it's important. But this is the journey that really I'm passionate about. So I'm excited to talk to you and share some of that little conversation we had in person with the audience today. So we have I have lots of questions for you, and I'm sure that the crowd will too. So everybody, Luncheon with the Experts, shoot your questions across. You know now what Pam does in her area of expertise. So just know if we can't answer 2 case-specific questions, so try to answer them in a generic form. Try to keep them in the realm of which Pamela is experienced. If we can't get to your question, or Pam has agreed to field any question that you ask, but if she can't answer it, we can certainly suggest a better route. But send in your questions. Just try to send them in to a topic that we're able to address today. So if we can't get to the specificity of your question, or you have follow-up questions, I always encourage you to reach out to Carcinoid Cancer Foundation after the program ends. You can message them here on the Facebook page. You can direct message them, or you can visit their website at carcinoid.org. So always follow up, and somehow, some way, we will get you the information which you seek. And before we get started today, I just want to let you know that we know how challenging it can be to be a NET patient, especially seeking diagnosis, especially being in, this pandemic of 2020. So CCF is here for you, however, whenever you need us. And if you'd like to show that support back and reciprocate that, an easy way to do that is with a donation, small or large, any bit helps. And a really easy way to make that donation is just by texting the word experts to the number 1-914-380-7323. Again, that's experts to 914-380-7323. Every donation helps. Genuinely, every donation helps. So first, everybody go ahead and start sending in your questions. I see everybody telling us where they're from. We see Nepal already, Canada, Norway. Hey, Kate. It's my favorite part about this program is seeing how far that we reach.
Yeah.
But before we get started, we got to give Pam a little shine, because I heard that last year you received the Monica Warner Award, which is awesome. And I just want to read a little bit about this. And those that are familiar with the foundation know the relevance of Monica Warner, and in fact that last name in general with Dr. Warner, Keith, the CEO. That's an important last name in this community. But I love this paragraph I'm looking at. It says, in nominating Pam for the 2019 Monica Warner Award, colleagues at NOLANETS referred to her as having her as the mothership to the nurses. Patients who have navigated the many medical and mental aspects of NETs describe Pam as being a ray of sunshine on a bad day, the voice of calm, a vital guide. Look at your accolades already. In short, Pam embodies the spirit of a great caregiver, nurse, educator, and friend, and the NET community is truly stronger because of people like her.
Wow.
I mean, quite a compliment. Tell me a little bit about that award. What does that mean to you, and what does that mean to the role that you're trying to fill in the community?
So, let me take a minute.
Starting off hot.
Oh, not too emotional, huh? It is a huge honor. Let me take a minute on that one.
It's okay. This is what we're here for.
I was around for the first award in 2009 when I had the pleasure of meeting Monica Warner and Richard Warner, her husband, and wonderful, wonderful people, wonderful advocates. And I never dreamed in a million years that this would be an honor to me. So it's speechless. Just, I can't say, it means a lot. It's truly come for full circle my whole career. I'm quite honored.
When did you realize that this was the direction you wanted to take your career?
With neuroendocrine?
Let's go back even before that, like with the focus so centrally on patients and helping them navigate that journey. Like, was this a characteristic that you had as a young woman? Like, when did you understand that you wanted to be in such service of others?
Well, I'm not really sure. I think I just did it. And then I realized afterwards, this is kind of where I was and where I ended up. So I guess that's who I am. Early on in my career, I was an ICU nurse. So very focused on task completion and making sure things were right, and very obsessed about being, a really good nurse there. But being a young nurse, you don't have that trait in you or that drive. I don't think you have that. You develop that over time. I mean, that's the way it happened for me. I don't know if that's true for everyone. 10 years into it, I kind of went into a new role, abdominal transplant, and I fell into that because of my children. I needed some more stability in terms of shift work. Shift work was really tough on my kids, so I needed some consistency and some routine. And I became a coordinator, and in a sense, I was a navigator there. We took the patients from, working them up for transplant, getting them transplanted, scheduling their living related or putting them on a wait list, and managing them, and then calling them in for a transplant, getting them transplanted, educating them. So that in a sense is navigation. And I never even knew it. But, that sense of helping guide people through that process really was rewarding. Rewarding for me, as well as I didn't know for them at the time. But I can only imagine, again, as a young nurse, you don't really appreciate that component. I guess with maturity and with age and with growth, you start to realize that maybe this is who I am and what I do. And then later on, Hurricane Katrina hit in 2005, and then I fell into this neuroendocrine world, which I really didn't know anything about. We started to take care of patients in our transplant facility for neuroendocrine because we were doing aggressive surgeries. We started we took call as nurses, and we started learning more. Patients were calling with symptoms and problems and octreotide issues and diarrhea issues. And we were like, what is all of this? So it was kind of forced learning. And then I had the honor and the privilege of working with Dr. Eugene Waltering and Dr. Lowell Anthony. At that time, they were at LSU. And they started teaching us a whole lot of stuff. And I saw the passion and the drive that they had towards this disease. And it just, they took me under their wing, and I just flew with it. So Hurricane Katrina hit, and we all kind of had to rebrand ourselves and relearn what our place was. So we started developing our neuroendocrine tumor multidisciplinary neuroendocrine tumor program, now known as NOLANETS. And we grew it and grew it and grew it into this big, wonderful place that we really help patients and make a difference.
Yeah, there's a lot that I have to say about that, but this concept of the multidisciplinary team we come back to a lot. In fact, we created a video about multidisciplinary teams and centers here at the foundation. So we've already, and we talk about this a lot on the show, why that's so important. I want to ask. I mean, we know it's important, but why? And don't take this the wrong way, but why is your job, your role on that team so important to the patient's journey? How what gap do you fill? Does that make sense?
Yes. Oh yeah, absolutely. I think it's a strong question and a great question. My role in that multidisciplinary team, I feel that I connect closest with the patient. Being the nurse, being the front line, I talk to the patient more, and I spend more time with the patient than the physicians and anybody else on the team. So I am the patient advocate. I speak up for the patient. A lot of people have a lot of different ideas about what the patient needs and what's the next step and what's the most logical thing and what's the best thing for the patient medically. But you really have to look at the whole picture. You have to identify the barriers, and you have to be the voice for the patient. And I think I'm the voice for the patient and the family.
Now, what are the unique challenges that a NET patient presents you in terms of their navigation or their journey that they are navigating? Because that's, I know we all know that disease can go so many different directions, and many of the cases don't have the same pattern. So what are some of the other unique challenges that you face or that a patient faces with this disease in particular?
I think two come to mind. First of all, the unique challenge of travel, distance. Most patients do travel. In fact, there was a study that was published that stated that 69% of the patients travel out of the state, out of their area for care for their neuroendocrine tumor. And another 11% are considering traveling out of state or out of the area for their care. And the primary reason was for better treatment or better care. And that couples with the second reason is education. The lack of education, because it's such a rare disease in most oncology practices, is extremely difficult. And it's important for the patient. It's important for us to help the patient through that. So they kind of couple together, the whole travel thing and the lack of education due to the rarity of the disease.
How do we address the lack of education? I mean, do we just keep doing what we're doing? Is there something that we can be doing better?
Well, we always can do better, and we strive to do better every day. And I think from day one, 10 years ago, 15 years ago now, that I've been doing this, I think one of my main focuses was education. Educating the patients, educating the community, and educating healthcare providers. So I do a lot of outreach in the community and the healthcare provider realm, as well as patients, to really bring awareness about what this disease is, how it can act, what are potential treatments. And that's kind of one of my driving forces for the last 15 years. So we can always do things better. We try to get creative, especially with this COVID thing. Things have certainly gotten really creative.
For sure, yeah.
Still stuff going on. However we can do it. Usually, I'm not the creative one. I'm the implementer kind of type. So people around me are very creative, and I associate with those types of people. Like you're one of them. You have ideas and ways to do things that are phenomenal, and I love it. I love to soak it in and learn.
But you take those ideas and you make them happen, basically.
I make them happen. I'm a doer.
Cool, very cool. I like that. Me too. So we have some questions coming in. I already told you that I can talk to you all day, but I don't want to take the time away from everybody. So I'm gonna get to some of these, and then we'll just keep having a chat. For those that are just joining us, we're here with Pam Ryan, nurse navigator, and we're learning all about what that means and the role she plays in serving patients of the neuroendocrine cancer community. Send in your questions about her role. I see a lot of people saying that they've had great experiences with nurse navigators, and also people saying that they wish they had a nurse navigator at their team.
Yeah.
So hopefully this is something that we can continue to educate people on the importance of this role. And everybody listening at home, go ahead and send in your questions. If you know somebody that would benefit from this conversation, go ahead and you can share the video with them right now, or tag them in the comments and get them here. But if they aren't able to make it, or you want to review the video later, just know that it'll be evergreen and it'll live right here on the Facebook page under the videos tabs. And starting Monday, we will republish it on the YouTube channel of Carcinoid Cancer Foundation. If someone doesn't have a Facebook account, they can access it there too. So Pam, we have a question from Karen. It says, can you explain the side effects from lanreatide, especially pertaining to the heart?
Well, with lanreatide, there are many side effects. And when you get started on lanreatide, of course, your provider should review what you can and can't expect. Some side effects are more prevalent than others, but with cardiac side effects with lanreatide, we see bradycardia occasionally. Now,
what is that exactly?
Bradycardia, the slow heart rate.
Got it.
A slow heart rate, bradycardia. So that is something that has been studied by Ipsen, the company who makes lanreatide or somatulin depot. And the data shows that there's been no correlation between why it happens, when it happens. A lot of times nurses, when educating nurses, other nurses about this drug, they ask, well, when does that slow heart rate happen, right? When I give the shot, does it happen after a month? Does it happen after 6 months? That's kind of what the nursing questions. But there's a lot to consider, and there's no real good answer. So sometimes it happens immediately, maybe because of a vagal response, like a low heart rate because the patient's bearing down, or it may happen in a week, it may happen in a month. There's no The data didn't show any pattern. The other thing we need to consider is patients who have pre-existing cardiac issues or a pacemaker. Some people have a pacemaker that protects them from the low heart rate. So really it's a medical judgment between the patient and their healthcare provider as to if it's safe to proceed with the lanreatide. I think it's reported a low amount of times, so it's not a huge concern, but this is something that the patient should discuss with the healthcare provider. If he's not comfortable or unsure, the drug company, Ipsen, can always, talk with the physician and help give guidance on that.
Great, awesome. Thank you. And thank you, Karen. Hopefully that helps. Next question, we'll move right along, Pam. Next question is from Pat. It says, what's the frequency of a somatostatin regimen being coupled with chemotherapy for metastatic carcinoid?
So frequency varies according to from provider to provider. For metastatic disease, we use a somatostatin analog on most of our patients in our practice. Every practice is a little different. Physicians practice differently, but for our practice, somatostatin analogs for metastatic disease is pretty much a given. And whether it's with chemotherapy or without chemotherapy, it's really individualized per patient.
Got it. So when we talked, when I saw you in person, you did a really great job. And often I should say, I really like to break down things in a visual steps, right? In the steps of this journey. So can you walk me through exactly what you might do with the typical patient? I know not all patients are typical, but that nurse navigator role, can you walk me through the stages of that journey?
Yes. So that's a very interesting question because nurse navigation is different in every tumor type. I've come to learn. When you say oncology nurse navigation, typically it's from pre-screening of a cancer, whether it's a colonoscopy or a mammogram. It takes you through diagnosis, it takes you through treatment, and it takes you through survivorship. So that's true navigation. Mm-hmm. Neuroendocrine tumors, these patients are treated mainly like a chronic disease, we've come to learn. So it goes on for years and years and years. So it's not to say that one navigator cannot take the patient through the whole journey, but it makes it extremely difficult. So in neuroendocrine tumor, and like I told you in the beginning, I kind of developed this role the last couple of years for neuroendocrine specific at our campus. So what I do is not the same thing as the other navigators in the Ochsner system. So a typical navigation for us in our center would be taking the patients through any change points. For instance, entry point. The patient comes in for a new patient appointment. We talk to them on the phone. We get a history. We gather records. We talk to any, if it's a physician referral, we try to get any of their notes and any of their input. We may schedule some baseline scans. We attempt to get CDs, pictures of their imaging, and then we set them up for an appointment. They may have some additional scans. Now with the whole COVID thing, we went to a lot of virtual visits. So we do a lot of virtual visits, and that takes on a whole extra layer of making sure they sign up for the patient portal, the electronic health record, because that is a necessity in order to do a virtual visit. Teaching the patient sometimes how to log into an account and create an account, showing them how to click on an appointment. That's all part of navigation. And that takes a good while. I mean, it varies from patient to patient. So then they connect with a physician, either in person or virtually, and then a treatment plan is made. That we may bring their case to Tumor Board. We go through Tumor Board. I help direct the Tumor Board conversations. I don't always connect with the patients on the back end. I couple with the clinic nurses in order to help take care of some of the other needs of the patients from the time they come in until the time they have some sort of intervention. So at their next point where they have an intervention, whether it's a surgery or a procedure or PRRT or what have you, I step in again. What I mainly do now is I focus on inpatients. We have a inpatient service where patients get surgery. We do aggressive surgery here at our center. It's not uncommon to have a census of 20 patients, and I round with the team. So our inpatient team includes me, who's the navigator, the pharmacy, nutrition, the residents, the surgeons, sometimes medical residents. We all round, and the floor nurses. We round as a team every day. And I just go through and make sure everybody's on the same page. People are collaborating. We have a plan in place. The patient understands the plan. The family understands the plan, answers any questions, and identify any barriers or needs that the patients or the family has, and gets that plan rolling. And then we have team meetings twice a week for the inpatient side. So I'm really involved with that piece. And then I help the patient transition home and really coordinate with their home doctor. About half of our patients live out of state. So that's a whole different animal in itself, if you will. Communicate with the home doctor, make sure that their appointments are in place, their follow-up is in place, and they understand everything that's going on.
So literally every step of the journey.
Every step, and you know, you can't do it all, and one or two
Right.
people can't do it all, so you really rely heavily on your team.
Yeah.
Rely on our clinic nurses here, we rely on the floor nurses, we rely on case management. I mean, we rely on the whole team to make it happen. And I guess my role is making sure everybody stays on track and corralling them in, if you will, if you need to move them forward, and making sure the patient has what they need.
Absolutely. I'm going to go back to some questions from the audience that are coming in. We have a question from Ebbs. It says, how effective is everolimus in carcinoid patients? Are there more success stories than not? And do studies show that it can be more effective than sandostatin? Any thoughts on that?
So thanks for that question. I would have to divert that to your provider. As we stated several times, every patient's case is different. The grade of the tumor has a lot of bearing on the decisions that the doctors make, whether you're on everolimus or not on everolimus. And then every tumor site is different. So that would be deferred to your medical doctor.
Gotcha. Okay. Thanks, Ebbs. Hope that helps. Next question from Wendy. Wendy says, I have my first palliative care visit next week. What should I expect? Off all treatment. I already had Whipple, liver resections, and hysterectomy, non-peptide receptor positive. So first palliative care next week. What should she expect?
So palliative care is a great component of our team. We utilize that service here at our hospital as well. And again, every center is set up a little bit differently with different goals and different expectations. But from our palliative care department, we expect and we work on goals of care and symptom management. So that's really what they focus on. And they really guide the patient to give them information about their disease process and about their options, and help really with the symptom management and pain and nausea and dehydration and things like that.
Got it. Thank you, Wendy. Hopefully that helps. Next question from Anita. What are your thoughts on managing the side effects of PRRT? And before we get there, let's establish what some of those side effects could be.
So PRRT, peptide receptor radiotherapy, is a treatment for neuroendocrine tumor patients with metastatic disease that have positive receptors on their tumors. So it's high dose radiation that targets the tumors and kind of stabilizes them and prevents them from progressing. So with that, there is side effects. Some of the side effects you may encounter are related to bone marrow, things that they can't feel, patients can't feel, but we can monitor and see in their blood work. That's why we do blood work periodically. It's radiation, so radiation can damage your bone marrow. It prevents your blood cells from producing, or your platelets can damage your platelets. Other things that PRRT for the side effects, again, patients can't really feel initially, but we can see in the blood work is kidney issues. Some of this stuff is cleared through the kidneys, so we watch the creatinine to make sure that the kidneys are not being damaged, or we hydrating the patient enough. We can see liver involvement or liver issues, so we watch the liver numbers. So those are all things that, again, they can't feel, but we can see. Some of the things that you may feel in terms of side effects may be nausea, but we have a nausea regimen we give patients prior to getting treatment to minimize any of that. Some patients report hair loss. Many patients, the most prevalent side effect that we hear about is fatigue. Many patients are really tired. They say midday they just can't go anymore. They have to go lay down and take a nap. Sometimes people have fatigue for a couple days. Some of them have it for a couple weeks. Some of it have it and it never goes away. So every patient is a little bit different.
What's some of the ways you would suggest a patient managing those common symptoms like fatigue, like nausea?
The nausea, in terms of the nausea, managing that, just medication mainly, bland diet, the fatigue, listen to your body. I tell every patient every day, listen to your body. If you're tired, go lay down and take a nap. Listen to your body. Sometimes you just can't do anything to get over that. Hydration is really important with these patients who are getting PRRT. That may help some of the fatigue, but it also helps flush the kidneys and helps minimize any strong radiation damage to the kidney. But overall, pretty benign, not a whole lot of side effects compared to a lot of other treatments we do provide.
Got it. All right, thank you. Another PRRT question, which is appropriate since you are in the PRRT room, right?
I am.
I've been in that room. Ruby says, if you've had Y90 microspheres treatment to your liver a year ago, is it too early to have PRRT?
So that's a great question and very controversial. So again, it depends on your provider. It depends on your multidisciplinary center making those decisions. We bring those to patients who have a change in therapy. We bring those patients to our neuroendocrine multidisciplinary tumor board every week we meet. And it's extremely important because everybody has different ideas and different ways to approach things.
Sure.
Medical people tend to have a medical view. Surgical people have a surgical view. Radiology people want to have a radiology view. But as a program, we have some guidelines and some ideas about how do we proceed with treatment and sequencing of treatment. Sequencing of treatment is extremely important for patients, and it's not really realized a lot by patients or providers out in the community. When you offer a treatment to a patient, you don't want to burn a bridge for a treatment down the line. So, why I say that is because if to the question's point, if you have Y90 microspheres, that's a radiation dose. And that could be hitting your bone marrow, it could be hitting your liver. And then PRRT is also a radiation dose. And maybe your bone marrow took a hit and you're not ready for PRRT, or it may disqualify you from getting PRRT because it's too much radiation and your bone marrow can't handle it or your liver can't handle it. So there's a lot of controversy around that topic in terms of sequencing, when, where, why, how, timing, if, do we not. And again, it's individualized. Some patients can tolerate it. Some patients absolutely cannot tolerate it. It can depend on your tumor burden. It can depend on your age. It can depend on your comorbidities. It can depend on, it's a lot of different factors. And that's why it's extremely important to discuss these patients in the tumor board and get everybody's input and really truly offer what's best for the patient.
Got it. Thank you. And thank you, Ruby, for your question. Hopefully that helps. Pam doesn't seem to be afraid of anything controversial.
I live in the controversial world.
We're going to stay right here with PRRT because we have a lot of questions about that, and I think it's important and certainly in an area where people could learn a lot. And everybody at home, we're about halfway through the program now. Go ahead and get your questions in. I just want to reiterate that if we don't get to your question or if you have follow-up questions, then go ahead and message the Carcinoid Cancer Foundation and we'll get you that answer or direct you to the person who can. But go ahead and send in your questions now. And here's another thing. If Pam is doing a great job and gives you a great answer, an easy way to let us visually know that is just by sending one of those little thumbs ups or the heart emojis. We all love those. And let us know that we're doing a good job and we're providing value. So if you get a good answer that helps you, that's just an easy way to just hit those and let us know that that was beneficial to you. Ooh, look, they're coming in. See, it's such positive reinforcement.
Oh, good.
So our old friend of the show, Pat Murphy, and soon to be guest on the show, has a question. It says, does it seem that people who have had PRRT can go off their somatostatin analogs, or is it advisable to stay on?
So Pat, that's a great question and also very controversial.
Yes.
So in our program, I can speak to our program and I'll speak to the study in a little bit. In our program, we feel we take a lot of patients off of their SSA with PRRT, and we have a lot of patients who stay on their SSA with the PRRT. Again, it's very individualized. It depends on what the patient is experiencing. Is the patient syndromic? That's one of the questions we ask. If they are, they probably need to stay on their SSA. If they're not syndromic and they progress, sometimes we take them off. So again, it does vary from provider to provider, but some people stay on, some people do not stay on. The study that supported and got the PRRT FDA approved does advise you to stay on your SSA for, I believe it's 2 years, while you're on the PRRT treatment.
Got it. Thank you, Pat, and see you soon. Appreciate you as always. So this will also be controversial. Ebbs has a question: is surgery for stage 4 NET that has metastasized stomach and lesions on the liver, it's often ruled as unresectable? Are there oncology surgeons out there willing to do surgery on this?
Absolutely. That is absolute yes. Again, controversial. Probably, I think when we looked at our data here, we're known here at NOLANETS for being very aggressive surgically. And when we looked at our data, we wrote a paper after we did so many surgeries for neuroendocrine tumors. And we identified that at least half of our patients were deemed unresectable by an outside surgeon. With that same data, our survival for mid-gut carcinoid was twice the national average for SEER data. So we do feel that we have learned a lot. We're doing something right. We're doing something good for the patient. It is very controversial. It goes against all cancer operation rules that physicians are taught. But neuroendocrine tumor is a different animal. It's a zebra. Remember, it's a zebra. You do things outside of the box, and that's what we do here. And we're very aggressive surgically. We're happy to evaluate you and give you an opinion. But the resectability of a patient depends on the skill level and the comfort level of the surgeon evaluating you.
Great answer. Love that. Just want to share this one with you, Pam. Stacy says, this is excellent information. Thanks, Nurse Pam. You are awesome.
Totally. Oh, you're quite welcome.
I totally agree, Stacy. I want to go back briefly to, you took us through the journey that you really, walk side by side, with the patient on. And often we talk here on the show about the overlapping aspects or the different pillars of health that are intersecting, right? And that all come together in our journey on this disease. So my question is, do you find that if you're doing your job well and helping them, and they have someone serving them, the patients have someone serving them as this liaison that helps them along this journey, mm-hmm. Do you feel like, or do you see that presents results where they're able to manage their disease better? Because often I feel like that having that stress of not knowing, what's going on, it's a rare disease, like that can't be good for you when you're trying to physically get well. What are your thoughts on that? Do you think that is providing more to them in a sense?
Well, I'd like to think absolutely it is advantageous for the patient. But doing this for so long, you see everything. Sure. You see one end of the spectrum where the patient is just latches onto you, the family latches onto you, and whether the outcome's good or bad, they are just totally ecstatic with you being there just because you're a familiar face. You're familiar with the disease. You might have done nothing else except listen to them for 30 minutes on the phone. And they may not have a good outcome, and they are so thankful and feel so much comfort, which gives me comfort and satisfaction. And then you also have the other end of the spectrum where no matter what you do and what you give, you're not sure if you're making a difference. You're not sure if you're helping or you're hurting. You have patients who don't want to be involved at all and they don't want to hear anything, just talk to my family, which is okay. And if I can help the family, that's just as well as helping the patients because the family's there for the patient.
Yeah. So how do you handle those days that are a little more challenging? How do you stay focused on your mission and purpose when you have someone who's just, because obviously having this diagnosis is more than stressful. That's not even strong enough of a word. So yeah, how do you handle it when it's challenging?
Well, I handle it pretty well when the patient resists but the family has the buy-in. And, because I can still empower the family and make a difference with the family. And in turn, it makes a difference to the patient. What I think I have difficulty with is the patients who are referred to a specialty center for a rare disease. And when we contact them, they say, oh, no, I think I'm just going to stay with my local doctor.
Mm.
By looking at the records that we can help you. We can help this patient. And they're not interested for whatever reason, whether it's fear, whether it's I can't travel that far. And you try to open them up and you try to say, okay, we can really work with you. We can work with your doctor. Even if you can't get here, have your doctor call our physician. Let's talk about a plan.
Yeah.
We want to help you. And some of them just shut down and they don't want to hear it.
Mm.
The other difficult scenario is when the family calls and they say, my dad doesn't want to do anything. My dad doesn't want to go seek care anywhere, but they're so desperate. They are so desperate for care and input, and they want their dad to come or their mom to come. And it's like, you can't make them come. And it's breaking,
Oh, see, you started off this episode emotional. Now I'm getting emotional. I had a dad like that, as well. And he did, but it was a struggle for him to seek out the treatment that he needed. Strong, silent countryman,
Yep.
So he did not want to do it, but at least he listened to us. But yeah. Whew.
Yes.
All right, I'm shifting back to questions.
Take a deep breath.
Take a deep breath. Nurse Pam, do you have any patients on sunitinib? And if so, how are they responding to this form of treatment?
We do use sunitinib a good bit. Our medical oncologist does. And I'm not directly involved with that care, so I really can't tell you in terms of specific outcomes. It is successful in a group of patients. We do see some side effects, as you would expect with any type of oral chemotherapy. But, overall, if they're tolerating it well, we'll go ahead and try them on it.
Gotcha. Thanks, Fred. Hope that helps. Still in the PRRT space, have you come across anyone who developed leukemia post-PRRT? Is there anything that could be done to reduce the chances of getting leukemia?
Yes, we have seen a handful. And usually that's a late side effect, 3 to 5 years, I believe is what it is.
Okay.
So, it hadn't been around too long. We've only been doing PRRT and it's been FDA approved less than 5 years. So I suspect we're going to see more because of the bone marrow suppression and injury. I do not think there's anything we can do to prevent it or avoid it. But I do think we're going to be seeing it more.
Got it. Thank you. Thank you, Anita. Myra, what's the next step for a narrowing and occlusion of the portal vein seen in a CT?
So that's a good question. And that is a controversy question. In our tumor board, we have radiologists, surgeons, medical oncology, all there looking at these images, and we talk about this every week. And there's many different treatments we can potentially offer, ranging from surgical to interventional radiology with stents. I mean, there's potentially many things that we can do. Intraoperatively, we use something called a nano knife, which that allowed us to remove tumors from around vital structures that were otherwise unresectable in the past. So what happens is they have instruments in surgery that burn the tumor away from things, and it's a hot burn. But with a nano knife, it's a cool burn, so it doesn't damage the portal vein and the bile ducts and things like that. So that allows us to remove more tumor that was otherwise unresectable in the past. So we have been pretty successful with that. But we're happy to look at films and make some recommendations if that is your case.
Got it. So we've got a couple of people asking about nutritional advice, and I just want to say to everybody out there, I keep reminding you that if we don't get to your questions, or if you have further questions, to reach back out to the foundation. But also a resource that you could use is the videos that I've helped them create over the years. And so if you go to the videos tab here on the Facebook page, you'll have all the Facebook Lives we've done, as well as the produced videos. And you can also see those on the YouTube channel for Carcinoid Cancer Foundation. And specifically, I bring that up because we have one on nutrition. We also have a Facebook Live that we did I think it was last year. 2020 has messed up my timeline. Like, I don't know what
Lost it all, huh?
a month ago or what was a year ago. But we do have videos on that. But while we're talking about that topic, and we do have some questions, we have a question from AJ or AJ that says, any food advice for vegetarians? Is there, any suggestions you have for them to get what they need when they don't eat meat?
So that is a great and a very, very important question. And we do have a nutritionist as part of our multidisciplinary team, and that she is probably one of the most important, in my mind, people on the team that really can help the patients. Nutrition is not my area of expertise. I usually defer to Tracy, is our nutritionist. I used to work with Leanne Burns, who I think is a friend to lots of people out there in the United States.
Certainly.
Learned a lot, but I kind of keep her in her lane and I stay in my lane. There's some things I know, but for the experts, I say go to the experts, and we're happy to connect y'all if need be.
Yeah, and what, Tracy, what's her last name again?
Cavalier.
Okay, yes.
Cavalier.
I'm familiar with her, but we haven't met. But Leanne is certainly a friend of the program and of the foundation, and she's been on the show before. So I think that's good advice to seek that out. This is the episode of controversy, and we already established that you don't shy away from it. So I had a question because you brought it up. The last question, you said this is not the nutrition one, but the one before that, you said this is controversial within our tumor board. And I remember having a similar conversation with you in person. I know that's got to happen a lot. Like, there's disagreement. I mean, that's the point of the multidisciplinary team, right? To have multiple perspectives on these difficult decisions. Right? That's the point. So my question is, I know that some topics and some discussions have to get, we don't, have to say heated, but I mean, where there are differing opinions, and some person feels strongly about this, some person feels strong. How do you navigate that? Like, what's your guiding light in those situations? Because that's difficult, but hey, that's what the board's there for, to make difficult decisions in the most educated manner, having all the experts from different fields, involved, including nutritionists, et cetera, et cetera. So when those moments hit, as I'm sure they do, how do you get through that? What is your focus on?
My focus, let me just say that happens every week. It's great. It's great discussion. It's great that everybody's participating, and it's great perspectives. As you said, everybody has their own perspective. And my focus in that scenario is keeping the tumor board on track, redirecting to where we are, what the real question is. And okay, we may not all agree. There may be differing opinions, which there oftentimes is. Typically, at the end of the day, when we're at gridlock and we're at
this is what I'm getting to.
Whoever is the managing physician of that patient typically has the final say. That's kind of how we handle it here. And it happens. And, one wants to do surgery, one wants to do an interventional procedure, one wants to treat with, chemotherapy or and one wants to watch and see. And here's a nutritionist saying, well, they're in poor nutritional state, they can't do A, B, and C. Here's research saying, oh, I want them for this trial. And here's nursing saying, well, they can't afford their medicines, or whatever the case may be. And there's lots of different things going on and lots of different dynamics. And there's gridlock. And so we sit there in silence sometimes, and I say, okay, so the question is, and what are the possibilities, what are the answers, and what do you want to do? And I usually direct it to their treating physician for the decision. But everybody's heard, and all opinions and perspectives are brought to the forefront. And sometimes we say, what does the patient want to do? Oftentimes they have a lot of good ideas about success and what's going to help the patient survive the longest and feel the best. And then I pop up, or one of the nurses typically pops up and says, well, what does the patient want to do? Sounds wonderful, but they don't want an operation.
Yeah, no, that's a really great and interesting point. You almost think that the patient should be part of that board, right? Yeah. And so since they aren't, effectively you're their
I'm the voice. I'm the patient voice.
Very, very cool. Yeah, that's such a great point. And I've talked a lot about multidisciplinary teams, centered around the patient, but I've never thought about it like that, where the patient should be one of those
Yeah.
people, because that's so true. I mean,
Mhm.
what's quote unquote best for them is often subjective, but also
Yes.
they may have their own thoughts about what they
Mhm.
want to do. It's their lives. And so that's
Absolutely.
a really great way to put it. And I know that
Yes.
they're glad to have someone like you there and the other nurses, to speak
Yes.
for them. I think that's a really
Yes.
important point.
Mhm.
But back to the like the gridlock and it's not easy to have those conversations and to bat that ball back and forth, especially when we're talking about someone's life there. But I think it's those difficult conversations that are necessary to actually make the best decisions in any
Mhm.
field,
Yeah.
and to impact and to have impact and to affect change moving forward. So it takes a strong person, to be able to have that and stay focused on the goal and not
Mhm.
just get into their personal feelings. Well, I believe this, and often people get caught up in trying to be right instead of figuring out what's right. And so I
Right.
applaud people like you and everyone on the tumor boards and part of those
Mhm.
multidisciplinary teams, because it's got to be difficult at times, but it's for the
Yes.
greater good. And so it's so beneficial to have that. And that's why any
Mhm.
moment that it comes up, I like to continue to beat that drum beat and reiterate that point, because I've learned this year how important they are. Okay, we have about 10 minutes left, everybody. Still got questions coming in, and still have a lot of people in attendance, which is exciting. A lot of people love you, Pam. You're doing a great job.
Oh, thank you.
Another question about PRRT from Pat. Are there any limitations on PRRT related to age?
That's a great question. We don't look at people in terms of a numeric age. We
Okay,
look at people in terms of a biological age. Some 80-year-olds can be really in good shape with
great point.
very little comorbidities and very active. And some 50-year-olds, they really can buy the 90-year-old price, tag.
Yeah.
Because they have a lot of medical issues. So it's really not the age, it's the miles. So no exclusions.
That is a great line. It's not the age, it's the miles. But that's very true. That's
Mhm.
very, very true.
And they use it in our tumor board a lot. It's not the age, it's the
Well, it's
miles.
my family, my mom is in real estate, and at a time of my life before I became a filmmaker, when I was deciding, I threatened with the idea of going into that world myself. I still love that world. I have some rental
Mhm.
property, and there's the actual age of a house, and then there's the effective age, and that's how
Mhm.
how appraisals happen. So I've got a 100-year-old house, but its effective age may not be that old, and
Right.
vice versa. So that reminds me of that
There you
time.
go.
Yeah, yeah.
There you go. You can
You can,
use my line if you'd like.
yeah, I'm going to.
It's not the age, it's the miles.
Yeah, I love that. Fred says, thanks for your response. You guys are always in the know. Well, Fred, she is, and our guests are.
Oh,
I'm just I'm the navigator of this
you're the
information.
navigator.
I'm the
Awesome.
vehicle in which delivers this information. I am not in the know. Honestly, selfishly, that's what I love about the show, is I learn something every week too.
Mhm.
Okay, a few more minutes left. Anita says, one of my concerns is finding a vein for PRRT infusion. How can this process be helped so that the pain that comes from poking around looking for a vein can be reduced? That's a common problem.
Yes, it is a common problem, and it's a great question. It's a real problem. I'm not sure if you have considered getting a port, but many patients who have vein difficulty accessing a vein do talk to their oncologist about a port placement, which is a little under the skin device that can be accessed. Many people who get chemotherapy have ports placed in their chest or their arm. And we do utilize ports for PRRT infusion. Some people have PICC lines. We have used PICC lines as well, which is more of a temporary. It's a catheter insertion into the arm that goes centrally. It's placed under fluoro, and that could be another option. But it is important to have 2 IVs going when you get your PRRT, one for the pre-meds or any emergency meds, one's for the radiation dose. And the amino acids can kind of flip-flop. But if you lose a vein during the treatment, you want to have one readily available so there's no time wasted and the drug doesn't decay.
Got it. Thank you, Anita.
Thank you.
Hopefully that helps. I have a question from Anna. may be too broad, but I'll let you make that determination. Can you take steroids with this cancer?
Yes. Quick answer. Yes. We do give steroids as pre-medications for PRRT.
Okay.
A lot of times. Steroids is not a typical treatment for the cancer.
Right.
So if you need to take it for another reason, say you have a poison ivy rash or something, or you have a back injury and you need some steroids, yes, it's perfectly okay to take steroids with neuroendocrine tumors.
Got it. Thank you. Jenny says, when does the tumor board meet at Ochsner?
At our program, the tumor board meets every Tuesday morning from 7:30 to 9:30.
Got it. All right. We're going to try to get as many as we can in the remaining 5 minutes. From Amber, how often do you see patients with with an appendix primary? Is it often appendix primary has disease progression?
So yes, we do see a lot of patients with appendix primary. They do have disease progression at times. It depends on the location of the tumor on the appendix. So your appendix is hanging off of your colon. And if it's at the bottom or the tip of the appendix, the metastasis risk is a lot lower. If it's closer to the colon, and we call that at the base, there is a higher risk of metastasis there, and therefore you need a right hemicolectomy surgery or more aggressive surgery. But beyond that, depending on the grade of the tumor, that has a lot to do with whether it's going to metastasize or not. So every case is very individualized.
Understood. Lorraine says, Nurse Pam, you are fabulous. You are amazing with your information. I'm learning so much from you in this show. That's awesome, Lorraine.
Thank you.
We are so happy. Yeah, this is why we do it. So thank you, Lorraine. She says, also, I get so caught up in listening to the questions and answers, I forget to send my own. Oh no, well, send them in anyway. We'll get to them when we can. Oncology nurses are angels. I agree, Gretchen.
Thank you.
Okay, let's see. From Lynn, my veins are a wreck, and the IV team brought in an ultrasound machine and found the vein immediately, and then the needle didn't hurt and went right in. Does that sound?
It's another technique. Absolutely.
Gotcha. And probably time for the last one. Sharon says, my ileocecal valve was taken out and everything goes right through me. My kidneys aren't doing well. How can I keep from getting dehydrated all the time?
So first of all, that is an important question. And first and foremost, you need a nutritionist. You need a nutrition consult. Our dietitian or nutritionist helps with that type of diet to slow down the transition through the ileocecal valve. It is unfortunate that it is missing, but there are some things we can do dietary-wise, medication-wise to help slow that down and treat it. But nutritionist, dietitian is extremely important.
Got it. Absolutely. So I want to ask you a final question that I like to ask all of our guests, if I can, because to me, I really think about this moment of getting diagnosed with this disease, which most people haven't heard of. And I don't want to say most physicians, but many physicians aren't as familiar with. It's got to be a scary time. It's scary whenever, you get a diagnosis like that, but I think it has to be, I feel like it would have to be more when it's like, well, what is that? What does that mean? So you're the patient advocate. This is who you work for. What would you tell somebody who just recently got a diagnosis for a neuroendocrine tumor? They got a long journey ahead of them. You're going to help them walk through the stages and steps of that journey. But in that first step from 0 to 1, what do you give them at that point? How can they, we always hear this expression, be your own best advocate. What are the simple things that they can do in that moment?
So initially what I would tell them is, you're not in this journey alone. We're here to help you. Although this is a very rare disease, we see this every day. We live and breathe this disease. We know a lot about this disease. We've been in this for many, 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 many years. We helped develop a lot of the protocols and the drugs. So we are familiar. You have somewhere to go. You have a lot of options. I want to empower the patient. I want to empower the family. I want to empower them to read about it. If they don't like to read, there's lots of videos, there's lots of oral education, but learn as much as you can about this disease. We are here to help you. Empower yourself to fulfill your body, mind, and spirit. Relaxation, decrease in stress, all of that is super important. I haven't physically faced the cancer diagnosis, but I'm told that, from everybody, that this is really a hard reset. I don't know what that feels like, but listen to your body. Mind that and take advantage of it. Slow down, enjoy your life, enjoy every minute, do what you can when you can do it. And, they have a different perspective, obviously, but, I need to let them know that they're not in this alone. If they have any question, we are here for them. If I don't know the answer, which I don't a lot of times, I can find it out. I'm a good resource person. I don't know everything, but I'm going to find out for you.
I know that about you. Yeah.
You know that about me. So that's my strong point. But, I want them to feel that they're on this journey with a team that is here for them, 24/7. No question is too crazy. I mean, I've heard crazy things, but no question is too crazy. If they don't want to talk, that's okay. If they want to talk, I've been on the phone for an hour and a half with a patient, just had it on speaker, and I'm listening to them. And they just want to talk. They need to talk to somebody who has heard this word before, who has heard this diagnosis before, because many people have not. Many healthcare professionals have not.
Yeah.
And that first step does the world for them. That's what they tell me. So.
Thank you. That's a perfect place to end the show for today. Actually, most important question, because I was one of those places you looked for resources from. Did you book a trip to the North Carolina beach?
I did not yet.
All right. I'll send more resources if you need them.
Please do. I'm looking.
It stays warm here for a while, just FYI.
Okay. That sounds good. It's on my bucket list. You know that.
I do. Pam, thank you so much. You were a delight to host, and the people have agreed in that sentiment. So I appreciate you joining us today.
Oh, well, thank you so much for having me, and I'm so happy to share and be a part of your show.
Absolutely. And thanks to you all at home for joining us today. We hope the program helped you. And as always, please reach out to carcinoid.org or here on their Facebook page. You can message them for further information if you have any other questions. And thanks again to our new presenting sponsor, Tercera Therapeutics. Without them, this program would not be possible. My name is Rain Bennett. I am your host. Thank you for watching, and stay healthy, stay safe, and join us next time on Luncheon with the Experts. Bye-bye, everyone.
Bye-bye. Thank you.